Hello, welcome to the series on vital signs. This is a really important fundamental topic for us as nursing students and nurses. This helps give us a really great baseline idea of our patient's condition. So let's take a further look. So when we talk about vital signs, we're going to look at these 5 main areas. Number 1 being our temperature. Just know, depending on the area of the body that you take the temperature, it's going to vary slightly, and we'll discuss this later. And number 2 was our pulse, otherwise known as our heart rate. Number 3 is our respiratory rate and how fast we breathe. 4 will be our blood pressure, and 5 is our oxygen saturation. So these big 5 components is what we call a full set of vital signs. As you can see, these are hitting many different areas of the body and our body systems, so it's going to give us a really great indication of how well your patient's doing. Now let's take a look at one more vital sign. We call this the 6th vital sign, otherwise known as pain. Now realistically, this is not a vital sign. However, this is really important information to collect on your patient because if a patient's actually in pretty severe pain, it can indeed affect some of these other vital signs, such as how fast you breathe, your pulse, or even your blood pressure, for example. So this is also a great baseline condition to make sure you assess on your patient. So why do we even take vital signs? Again, it's a great determination of a patient's baseline health status. Now with these vital signs, we can identify some potential problems that may arise and hopefully implement interventions early. Then we can evaluate those interventions and see if they were effective for our patients. And again, this is going to give us a more accurate understanding of our patient's baseline health. So one thing to note is many times as a nurse, when you go in and assess the patient visually, we may see some indicators with the patient that, they may not quite seem right, but maybe nothing too alarming. Well, vital signs are a good tip-off that there could be some changes with your patient's hemodynamic status or their baseline health. So again, another great assessment piece when you're taking care of your client. Let's discuss guidelines for measuring vital signs for a client. There's a lot of important points to consider, but we'll talk through each one. So first and foremost, making sure your equipment is functional is very important. And we also need to consider it's appropriate for the size and the age of the client. An example of this is there's pediatric cuffs when we're obtaining blood pressures for a client, for a pediatric patient. Also know that the size of the cuff matters in regards to the accuracy of the reading. So if I have a really small cuff for a patient's arm, this can give us an abnormally and false high reading. The same is true if the cuff is far too large. We can have a false low reading. So this is important in regards to the size of our equipment and considering the age of the client. And don't forget about delegation. Vital signs is something we can typically delegate to our unlicensed personnel. But it's also important to note that there are occasions where it's not appropriate, so as a nurse we need to use our judgment. We also want to be able to understand and interpret those values we obtain. If we have a set of vital signs, we need to know what they mean, right? Otherwise, we're just looking at numbers. The same is true as knowing the client's usual range of vital signs. This becomes important because some patients' blood pressure, what we call trend, and normally runs lower than maybe the 120/80, that's a normal blood pressure range. The same can be true as well when we're talking about heart rate. Some patients' heart rate may run a little bit lower, and that's normal for them. We also want to determine the client's medical history, the therapies they're getting, and the prescribed medications can all affect their vital signs. We also want to control or minimize environmental factors that affect vital signs. Here's a great example of that. In healthcare, you may hear something called white coat syndrome, or you may have this yourself. All we really mean by that is I will tell you, when I used to work in a cardiology clinic, patients would come into the office and their blood pressure and heart rate would be really high. It really just had to do with The doctor made them nervous, so their blood pressure and their heart rate were elevated every time they came in. But they would give us readings of blood pressures at home, and they were much lower and much better results. Keep this in mind that there's different factors that can affect patients' vital signs. We also want to consider using an organized, systematic approach when we take our vital signs. When we get a set of vitals, we want to take a full set of those, meaning all the temperature, the respiratory rate, the blood pressure, the pulse. All of those pieces matter, so we want to do it in an organized and systematic way. That way we make sure we're accurate and we obtain all the results we need. You want to consider as a nurse the acceptable ranges for medication administration. Many times we have to use vital sign measurements to determine indications for meds. Sometimes we've got to give medications to lower that blood pressure, for example, or even to increase the blood pressure. Whatever findings that you get for vital signs, we need to be sure to communicate those, which may mean that we are accurate in our documentation. There's occasional instances where we've got to communicate abnormal findings to a healthcare provider because they could mean a decline in a patient's status. And of course, always analyze those results of vital sign measurement because analyzing this is going to matter in regards to the patient condition and their treatment. And don't forget to instruct the client or their family or the caregiver in vital sign assessment. This is really important because if they're monitoring these at home, they need to know, is this a significant finding? Do I need to call my doctor or not? We talked about many guidelines for measuring vital signs. This helps emphasize health promotion and activity that helps support our health. So again, you may need to teach a client and their families to assess and record their vital signs. Also stress that these vital signs need to be taken at the same time every day. There's different times throughout the day that our vital signs are naturally going to change. So stress when you're doing education with your family members or your patient that they take them at the exact same time every day, if at all possible. In regards to recording vital signs, let's talk about 4 points to keep in mind. We want to make sure we record the values on either our electronic health record or the paper graphic, whatever your facility is using at the time. We also want to record in our nurse's notes if there's any accompanying or precipitating symptoms of a patient's vital signs. This could be key information for the healthcare provider later. And of course, there's times when interventions are needed for abnormal vital signs. It's important that we document those interventions and the follow-up. And if a vital sign is outside anticipated ranges, this is a point where we may need to consider contacting the healthcare provider. So let's take a look at some guidelines when we're talking about safety and performing vital signs. It's really important to communicate clearly with members of the healthcare team. This could mean that we had to discuss precipitating symptoms of an abnormal vital sign, or maybe clear and accurate documentation in the record. Also, of course, make sure you assess and incorporate the client's priorities of their care and their preferences, and always use best evidence when making decisions about your client's care. Let's talk about a few more safety guidelines when we're measuring vital signs for a patient to ensure safe, individual, client-centered care. Now, a really important point is to clean your devices between client uses. This is going to help decrease the risk of infection. So here's another really important point to note. Many times your patient's going to be in special precautions that are ordered by the physician, such as contact precautions, airborne precautions, for example. Now, there's certain agency protocols on how we clean that equipment, so make sure you check your agency's policy. Also, make sure you rotate your sites when you're doing repeated measurements of vital signs like blood pressure or pulse ox, for example. This can decrease the risk of our skin breakdown. Also, it can actually give us an inaccurate measurement. Here's what I mean by that. If I take a blood pressure on my arm, I take one really quickly and pump up a cuff, and then maybe wait 30 seconds and do it again, and then do it in another 30 seconds, that can give us an inaccurate reading. So make sure you rotate sites if you have to repeat measurements. And of course, make sure you analyze those trends for vital signs and report any abnormal findings. Just keep in mind that each patient has a little bit different baseline on their blood pressure, for example, or their heart rate. If there's something abnormal here, make sure you report this to the healthcare provider. And of course, determine the appropriate frequency of measuring those vital signs based on the client's condition. Here's a great example of that. If a patient's in the intensive care unit, for example, many times the patient's pretty ill, so we may have to do these vital signs very frequently, for example. Much more frequently than maybe a patient on a medical surgical unit. However, many times you're going to have a physician order for that that's appropriate for your patient. Now that we've gathered all of our equipment, now let's look at actually inserting the IV. So number one, make sure you put on gloves. Then we're going to apply the tourniquet to the arm. We then want to assess the veins and see which insertion site's going to be best for us. Now, once we've found our site, we want to release the tourniquet. Now, we do this because we want to locate our vein. Then we want to release this because the longer that tourniquet's on, the more circulation for your patient can be impaired. So that's why we release it at this point. Then once we found that site, we're going to clean this thoroughly with alcohol for at least 30 seconds. So now that we've gotten our equipment ready, now let's talk about the actual IV insertion. So because I'm going to make contact with my patient, I'm going to first put on gloves. And when I'm using my gloves, I can use standard just clean gloves for this procedure. Sometimes they stick. All right, so here's something also to know about gloves, especially when they bunch up like this. So with a skill like IV, you really don't want gloves that are too loose because that may make it difficult to palpate or feel the vein. So it's nice to have some that are a little bit snug as well. So that's something to consider. So next I'm going to apply the tourniquet, which is this nice stretchy blue thing that's going to come into your kit. This is what's going to help apply pressure to the arm. So when I apply this to my patient's arm, know that once we apply it, it's going to be a little bit tight. So you may want to forewarn and let your patient know about this. So here's the key when we apply it. We're going to go underneath the arm, and everybody does this just a little bit different, but I'm going to pull it close. Do you see where my hands are close to the patient's arm? I'm going to pull it nice and taut, and then I'm going to cross them over. So you see how my right and left hand cross over? This is a skill in itself, I know. But I cross my hands over and hold them with my left hand. So what that allows me to do is to grab this piece that's still nice and taut, put my finger here in the middle like making an X, and then I'm going to loop this ear underneath the patient, or excuse me, underneath the tourniquet itself. So we're going to have a loose loop here, and you're going to see that tail out. So hopefully that makes sense to you. So if I need to release it, it's going to look like this. So I'm going to show you one more time what that looks like. Students typically struggle a little bit with this skill, so this is a nice thing to practice. So I'm going to put this underneath the patient arm, and again, the closer that you put it towards the patient arm, it makes it much easier to keep it nice and tight. What we don't want is a very loose, as you can see, tourniquet, because what is that doing? Not a lot, right? Okay, so let's relook at this skill part. So when I'm putting on the tourniquet, if you will hold it nice and taut, close to the patient, cross over your hands. If you will hold on to it with the left hand, and we're trying to make an X. So once I've made that X, I can hold these together, and I'm going to loop this left side underneath, and do not pull it all the way through, and here we've applied our tourniquet. So this should be nice and tight on the arm. So know the longer we keep this on, this can definitely impede circulation, so keep that in mind. So now that this is on our patient's arm, now we get to assess the veins and see which insertion site we want to go. This is a good time to really make a decision on where we want to go before we stick. Now, when we're looking at our patient's arm and we're choosing a site, one thing to remember, you do not want to stick on the inner wrist of a patient. Reason why this is very uncomfortable and there's a lot of nerves. There's some very tempting veins here for sure, but this is a high risk area of really causing some sort of nerve damage for your patient. So try to avoid the inner wrist if possible. So when we're looking at veins, we want to start with IV catheter insertion from distal to proximal. The reason why we want to do this, if we start an IV down here and we have complications, we want the ability to move up. All right, so when we're assessing IV, what we want to look for is there's great veins in the hands, but this can be uncomfortable if a patient's eating. I have a personal favorite. There's some that are here on the side as well that kind of run the thumb side, and you can kind of see me pressing on it. Also, of the very popular, there's some in what we call the AC or antecubital on the inside aspect of the arm. So when we're doing this, you want to make sure you palpate that vein and it's nice and bouncy. Once we've identified that site, we want to release the tourniquet. So I'm going to go ahead and release that so we can give his arm a break. So again, just to talk about vein selection, avoid the inner wrist. There's some great ones on the hand. There's also some nice ones on the side of the thumb. Also in the AC or antecubital area is a very nice place to go because it's easy to visualize, and usually you have a large vein here and there's typically a pretty easily identified site in the AC area. So as the nurse, you need to choose of what's going to be best. All right, so again, here's the other thing about IVs is you can see on Peter's arm, you can see lots of coloration of what the vein would look like. That doesn't mean it's going to be a great vein to puncture. So let me say that again. You can see the different colors of where Peter's veins are here. Now the problem with that doesn't mean it's good for IV insertion. So we want to go by feel. So when we go by feel, when the tourniquet's on, when we use our finger and push, or what we call palpate the vein, you should feel a nice little bounce. That's what we want. So that's the vein to go for. All right, one more really important key. If you're in this area and you're going to feel a vein and you feel a pulse, that is an artery. Do not stick that. I'll say that one more time. If you're in this area and you feel or see a pulsating, that is not what we want to stick. That is an artery, not a vein. And this is peripheral IV insertion. So just keep that in mind. All right. So once we've identified that site, considering all those things, release the tourniquet. And now that I know where I want to go, I'm going to take my cleaner and make sure this is clean for insertion. So depending on your IV start kit, you have options. So this particular kit has what we call ChlorPrep, pretty handy little guy here. So we're going to point this down and we're going to crack this, and you usually can hear it. Hear that nice little crunch, very satisfying. So we're going to make sure this is feeding the pad, and we're going to really scrub this in a motion for at least 30 seconds. So as you notice, I'm using a nice circular motion, and notice I'm not just cleaning the site, I'm cleaning everything out and around of where that possible transparent dressing and where I'm going to be. So this is ChlorPrep. Now, some kits may come with what we call an alcohol pad, which is really common for most of our procedures. So you can also do the same thing with an alcohol pad. Open this up and do the same sort of circular outward cleaning. Now that we've cleaned the site, we're going to reapply the tourniquet. Then at the insertion site, we're going to use our non-dominant hand to stretch the skin and stabilize the vein. This is going to help keep the vein in place. Then we're going to place that IV catheter on top of the vein at a 10 to 15 degree angle. So we're going to puncture the skin and vein wall and watch the blood flash back in the catheter itself. Then we're going to use the hand holding the IV catheter, use our dominant index finger to separate the catheter from the needle and advance it into the vein. Now at this piece, we want to make sure we advance the IV catheter all the way to the hub. Next, we're going to hold pressure above the insertion site with our other non-dominant hand and hold the hub of the catheter in place so it doesn't wiggle. Now we can release our tourniquet, and with the same hand that is holding the catheter, using the dominant index finger to activate the safety mechanism and remove the needle itself. So if you see this picture, notice that we're only advancing the plastic part of the catheter and the needle part itself is removed. Okay, so we just identified our vein and we clean. So now we're going to move on. So I'm going to go back to reapplying the tourniquet. And if you guys remember, we're going to hold this nice and taut. Whoop, a little too taut. Nice and taut. And then cross this over. And then I'm going to hold and support it with my finger here, make that X, and then loop this back through. So this can be nice and quick release when I need it. So notice I've put this a little bit higher up on the arm for my patient. All right, so now I can get my catheter ready. So when I have my catheter for needle safety, I want to make sure I go straight out. So every device is a little bit different, so we need to keep that in mind. And before we puncture the skin, we need to be able to see the bevel up. What that means is when I look down at my catheter, I can see a little bitty hole, and that's what we want, bevel up. All right, so now that I've cleaned, I can advance. So I need to hold my skin taut. And now when I puncture, I'm going to go at a very 10 to 15 degree angle. I don't want to go like this because I can puncture through the vein. All right, so now that I've punctured the vein, so now that I'm in the vein, what I'm looking for is flash. So as soon as I get flash, I want to go ahead and lower my needle and making sure it's flush with the skin and advance the catheter firmly and smoothly all the way to the hub. Now once I've done this, this is where it's going to go fast. So you want to make sure we release our tourniquet. I want to make sure I hold on to my hub so I don't lose my sight and hold down on pressure. I'm going to push my ejection button and I'm going to release the needle. Then at that point, this is where I'm going to go ahead and I'm going to put on my pigtail here. Now that we've got our injection prepared, we're going to expose the administration site, and then we're going to clean with an antiseptic pad, moving in a circular motion. So remember to clean thoroughly here to decrease risk of infection. Next, we need to remove the needle sheath and then position the syringe at a 90-degree angle. Okay, so positioning is important here for a lot of different reasons. When you go to give an intramuscular injection, you want to be head on. So I'm not very tall, so this usually isn't a problem for me, but if I'm really tall and I need to inject a patient with their arm here, you can imagine me going at a 90, it's going to look more like this. So please make sure you position the patient, you position yourself to get straight on and go at a 90-degree angle for your patient. With IM injections, 90 degrees is the preferred method. Then once we're in position, we're going to quickly and smoothly insert the needle into the subcutaneous tissue and into the muscle itself. Because remember, this is an intramuscular injection. Then after that, we're going to slowly inject the medication. After we've injected the medication, we're going to withdraw the syringe slowly from the muscle, and then we're going to make sure to immediately activate that safety shield on the needle. That's really important that we activate that safety so we don't puncture ourselves or the patient. Now after the injection, your patient may bleed a little bit, so please make sure you have a gauze pad and you can apply that over the injection site if need be. Now, most of the time, we can cover that up with a good old Band-Aid or maybe a Mickey Mouse Band-Aid or whatever your patient prefers, but usually that's sufficient. Then we want to make sure our patient's okay, they feel all right, we give them a minute to make sure that they are comfortable after that injection. Now that we've talked through that, let's take a look at the injection itself. Now let's take a live look at IM injection. So with my patient, positioning is really important. So notice, luckily I'm not very tall, I've got my patient positioned to where I'm at a full 90-degree angle. So notice when I go give an injection and I want to give a 90-degree injection that I am head on and straight with my patient's arm. That's really important. Also note, I've got my patient relaxed as much as possible, even though there may be some anxiousness. Try to have your patient relax, try to have their shoulder relaxed, and notice that his arm is in line with his body and sitting there and supported. So that's another thing to consider. All right, so today what I'm going to do is demonstrate a deltoid injection. I've talked previously in regards to injection that this is the most common site that you're going to use, and it's going to be in the deltoid, which is the arm. So let's talk about how we landmark that. So first, when we do that, we're going to try and take our fingers and find our patient's acromion process. That's going to feel like the really bony part of the top of the patient's shoulder. I like to creep my fingers all the way down to where I can find the edge of the acromion process here with about my third finger. Do about 3 finger widths down, and then right here is where I'm going to inject. The other thing you can do is kind of visualize a triangle of the deltoid, and you can go anywhere inside that triangle. All right, so now that I found where I'm going, I'm going to clean that injection site. I'm just going to use an alcohol pad and make sure that I start in the middle, and then I'm going to clean in a circular motion the whole area of the patient's deltoid and where I'm going to be going. And then just for a reminder, I'm going to find the edge of the acromion process about 3 finger widths down and then go right here in the middle of that. All right, so now that I've cleaned, maybe your patient could bleed after you get done with the injection, so it's always great to have a Band-Aid ready. A great tip, you can even put it on the back of your glove, that way it's handy for you. All right, so when I go give an injection, so with the needle that I'm using, there's a safety device, which is a great thing. We just want this out of the way for injection. So I'm going to move this device, and I'm going to pull this all the way back. So that way it's out of the way of the needle. Then anytime I go give an injection, notice I've got a firm grip and a dart-like grip on the syringe itself. So now that we've got that ready, I'm going to take the sheath of the needle and uncap it. I've pulled this away from my body and away from my patient. All right, so when I go to give the injection, I like to put my other non-dominant hand here, position myself straight with the arm. I like to take the non-dominant hand and really support the muscle, which also stabilizes me. And then I'm going to go in a 90-degree angle. Okay, sir, go ahead and deep breath out, and I'm going to give the injection. Notice that I darted in all the way to the hub. I'm going to inject the medication. Once the medication's in, I can pull out the needle, let the patient's arm relax, and I like to use the bedside table to get the needle away from me and my patient. I put this here and just let this click. That's the click you want to hear. Now, this is nice and covered and safe. So, luckily my patient's done really well, right? He stayed relaxed. Keep in mind where you have your patient when you do this. Luckily he's not bleeding. If he does, we've got our Band-Aid here. We can go ahead and apply. But one thing to consider, anytime you have a patient up and you're going to give an injection, some people may get a little woozy. So if you think that person is it, then you may want to lay them back in the bed. Also, with an intramuscular injection, sometimes these are painful, sometimes the medication is thick. This injection is okay to massage the site. So after I've given the injection, I'd like my patient to sit in a waiting room maybe, or sit nearby. That way we can assess the patient for the medication effectiveness and also make sure my patient doesn't have any reactions. With the intramuscular injection, there's several considerations we can look at. So first of all, what do we don't do? Now, after we give that injection, I know that it's a good accomplishment, we get that thing in, but once we inject the medicine, don't withdraw it too quickly. Give the medication a time to make sure that we've got that in the muscle. Then make sure you administer the injection into the intramuscular space, not into the subcutaneous tissue. And this is partly important in regards to our needle gauge and our size and length for our patient. Now, things to make sure we do when we do an injection in intramuscular is know those landmarks. Know those anatomical landmarks. That's really important as a nurse and a nursing student, because if we don't give those appropriately, it can really cause damage to our patient and really cause pain and discomfort and further complications. Also, don't forget, anytime we give a medicine, we want to prepare the medication immediately before we administer it. And if it's applicable, we need to rotate sites if this particular intramuscular injection is routine for that patient. I'd like to take a moment to talk about a few alternative injection details that you may see in clinical practice. Now, the two following methods that I'm going to talk about, you really don't see as much in the clinical setting. So let's talk about one to start. One of those is called a Z-track method. Now, it really is best practice to use this method. The reason why we use this method is to help prevent any leakage of meds into the subcutaneous tissue. The theory is that you're going to get all of the medication into the muscle, and you're commonly going to use it for meds that may stain the skin, for example, such as an iron intramuscular injection. Now, really is best practice, but I'll just be straight with you. This is not a method that you're going to see a lot in a clinical setting. But let's talk about it. So first here, if you take a look at the image, the whole point is that you are making kind of a zigzag pattern, why we call it the Z-track method. So if you take a look at this first image, you see here that we are pulling the skin slightly to one side before we insert the needle. Now, while still holding that skin, we're going to insert the needle and inject the medication with our 90-degree angle, just like we've talked about previously. And lastly, when we remove the needle, this is when we're going to allow that skin to bounce back and return to its natural position. Next, I'd like to talk to you about aspirating for blood. Now, this used to be the most common practice when I started nursing school and used to learn how to do medications or IM injection. So the point of why we used to aspirate for blood is to ensure that the injection is actually in the muscle indeed and not in the vascular system. So, do we do this in practice or do we not? Well, really, we have stopped using this technique, and this is why. Most injection sites don't really have major blood vessels present for this to be a concern. The other thing to think about is there's a little bit more risk if while I'm in the muscle that I pull back on the plunger and then I've got to make sure and kind of handle all this while trying to do the injection. There's more risk of moving that needle around in the patient's arm. So we've eliminated this practice. So again, this is to ensure that the medication will not be injected in the vasculature, but this is a practice that you should no longer see. Also, this is not recommended when giving vaccinations. And many times when you're giving an intramuscular injection, vaccinations are going to be one of the most common intramuscular injections that you're going to see. So here we want to go ahead and assess the client's vein to select an appropriate venipuncture site. So if you see here in this image, they're going for what we call the anticubital or AC. That's a very popular venipuncture site. Now we can apply our tourniquet and then use alcohol swabs to clean. Now it's really important when you clean that we don't retouch the site after it's been disinfected. Now once we've cleaned, we can now remove the plastic protective sheath from the needle and then immobilize the vein using your non-dominant hand. That way it doesn't roll around when you try to stick. Now we can use our dominant hand and insert the needle at about a 30-degree angle. Now make sure that bevel is up. So when we're talking about bevel up, remember we should be able to look down and see a little hole, and that's how we know the bevel is up on the needle. Now once we access that vein, keep the needle stable. Then we can use our non-dominant hand to insert the blood collection tubes into the blood transfer device. Now just keep in mind when you're using a winged needle, the waste tube should be used so that the air within the tubing is not displaced into a blood collection tube. Now we can release the tourniquet once the blood begins to flow freely into the first blood collection tube. Now we want to fill the required blood collection tubes by replacing each one in each filled tube with an empty tube. And once we've collected all of our labs, we can place our gauze over the insertion site and withdraw the needle. And of course, activate the needle safety device. Now it's a good idea to hold pressure to the insertion site using that gauze until the bleeding stops. We want to now place the needle into the sharps container. Gently invert that filled blood collection tubes to mix the blood with the tube's additives. And of course, don't forget to label all blood collection tubes at the client's bedside. Now place the blood collection tubes into a laboratory biohazard bag. Okay, so when we don our gloves, it's important here to assess the client's veins to select which venipuncture site we would like to use. Now, many times it's very common that you will see a venipuncture in what we call the antecubital or the AC site. So now we can go ahead and apply our tourniquet. So if you remember when we do our tourniquet, I like to hold it a little bit closer here, and this is just going to provide some more tension. Then I like to cross my hands and gather it in one to where you see a nice X. Then I'm going to poke through just this little side here. So when we're done, we can quick release. And again, I'm going to show you the tourniquet one more time. I'm going to grab the size here just for a little bit more tension. I'm going to cross my hands. And I want to just make sure we gather this in an X-like fashion. Then I'm going to take the tail and poke this to where it does not go all the way through and leave that there. So once we've got the tourniquet, now I can clean my site. I'm going to take my alcohol pad and then I'm going to go here and make sure that I thoroughly clean with the alcohol swab. And it's important here to make sure you let this dry. Now once you've done that, we can remove the plastic protective sheath from the needle. So this is the plastic part and I'm going to pull straight out. And this is what's great about these needles. They have these little wing devices that I like to hold on to for the insertion of the needle. Now once I've done this, I can immobilize the vein using my other hand. Now with my dominant hand, as you see here, I'm going to make sure I insert the needle with the bevel up. So if you remember when you're talking about the bevel, if you look down at the needle, you should see the eyelet or the hole of the needle looking up at you. So now that I've done this, with the bevel up, I'm going to access the vein. Now once we've been successful in accessing the vein, do your best here to keep the needle as stable as possible with your dominant hand. Then you will use your non-dominant hand, and that's what's going to help you to insert your blood collection tubes into the blood transfer device. Now just keep in mind here, this is just my personal preference, but I used a butterfly or a wingtip needle. Now sometimes because of this extra tubing, there can be some air that gets into the tubing. We do not want this in our lab sample. Therefore, it's a great idea to use an extra tube of what we call as a waste tube just to remove the excess air. Now once we're ready, go ahead and that blood is free flowing. Go ahead and release your tourniquet here. Now we can go ahead and take our waste tube, and I like to just keep it here flat. Take my waste tube, stick it into the blood transfer device and push the end. Now what's really neat here is this gray that you see has a puncture that will release the vacuum to help pull the sample. So I'm just going to push this all the way to the top and it's going to fill. Now once we decide that there's not any more air into the line, we can remove this by simply just pulling this off, get rid of our waste tube, and then replacing it with our lab collection tubes. And then again, going to stick it here, push this in all the way till it punctures, and then make sure that fills appropriately. Now once we've got our blood collection tubes, then we can go ahead and remove these and then place the gauze over the insertion site. Now once we do this, we want to go ahead and withdraw the needle. So once we withdraw the needle, go ahead and pull this out. Then it's really important to activate the safety device. So what I like to do here is just hold my wings and very carefully slide the yellow, which is the safety device, over the needle until it clicks. So now I'm going to put this to the side. So once I've done this, I'm holding pressure. Once we've decided the bleeding stops, it's a good idea to go ahead and tape this down. And if your patient has another hand, they can help you here as well. Okay, so now that we've got this down, just remember that you want to take your needle here, and we can remove it from the blood collection device and place this into the sharps container. Now once we've done that, it's a good idea that we gently invert our blood collection tubes. So when we do this, we don't want to shake this. We just want to simply take this and gently invert it to mix the blood with the tube's additives. Now it's also important to note that once we invert it and we're ready, you've got to make sure that you label the blood collection tubes. Now you want to do this at the client's bedside to make sure you get the right patient and the right date of birth. Also know that sometimes you can get this label from the electronic medical record or the patient label, so make sure you follow your agency's policy. Now once we're labeled, we can go ahead and place our blood collection tubes into the laboratory bag. And it's also important to note that all specimens that have any sort of blood or body fluids need to go into this type of bag. Now that we've drawn up our medication from our subcutaneous injection, we're going to now do the injection itself. So first make sure you expose the administration site and clean that with an antiseptic pad. Usually that's going to be an alcohol swab. So now let's remove the protective sheath of the needle. So now we're going to use our non-dominant hand and grasp the skin around the injection site. So really here, all we're doing is taking that hand and kind of plumping up the skin to give us a nice surface area to inject. What we don't want to do is pinch really narrow because our hands can get in the way, or we don't want to pinch really hard because that can be uncomfortable for the patient. Next, we're going to take the needle and do it and inject in a very quick, smooth-like motion. So we have options. You can either go at a 45-degree angle or a 90-degree angle. So something to note, most of your patients of a healthy weight or maybe even a higher body mass index, you can go a full 90-degree angle because this is safe, and also remember how the length of those needles are, they're pretty short. Also, sometimes you need to consider you may need to use a 45-degree angle technique. Now this is less common because this is really going to be used on the patients that are maybe even emaciated, really underweight or under body mass index, or someone that's malnourished. So 45-degree angles injections are more rare. 90-degree angles are really going to be what you go by, and usually the most common. So now we're going to inject the medication and then release the skin held by your non-dominant hand. Then we can remove that needle quickly and smoothly and make sure we activate that needle safety promptly to withdraw the needle and make sure that needle is safe and covered and out of the way. Now that we've drawn up our medication, let's take a look at the actual injection itself. We want to make sure our patient's nice and comfortable, then we're going to choose our injection site. Now for this demonstration, I'm going to use the abdomen. Alright, so then I'm going to expose the site, but also try to leave the patient as covered as possible. So I only need to expose a little bit of the patient's abdomen to give this injection. So before I give the injection, I want to assess the site, make sure there's no wounds or scars on the place that I'm going to inject. Typically we want to go at least about an inch out from the belly button, and anywhere here on the abdomen we can go all the way to the love handles, if you will, on the side of the stomach. Alright, so now we're going to prepare our site and we're going to make sure we clean thoroughly. So this can be kind of cold for your patient, so make sure you scrub and clean your site appropriately. Then when we go to give the injection, I'm going to grasp the patient's skin and where I'm going to inject. So when I do that, I don't need to pinch really hard or pinch really narrow because I don't want to get my fingers in the way. I also don't want to make it painful for the patient. All right, so now let's also talk about the angle. Now my patient's at a healthy weight, so here we're going to go at a 90-degree angle. If my patients may be emaciated, malnourished, or have very little adipose tissue, we may need to consider going at a 45-degree angle. But for this demonstration, my patient, we're going to use a 90-degree angle, which is appropriate. Alright, so now let's get ready for administration. Now this particular syringe I have in my hand, notice the orange cap. Now the great thing about this is universal for the sign that it's an insulin syringe. So you should only have insulin in an insulin syringe. So it's a little bit different for the fact that this is counted in units when you give insulin. So again, it's really important to pick the appropriate syringe for the right medication. Alright, so notice that orange cap, think insulin. Okay, so now we're going to remove our cap. Notice when I pull it away from my body. I pull it away from the patient. I'm not pulling it this way, so where I accidentally stab myself. So please make sure you keep this nice and away from you and the patient. So I'm going to move this off and pull. So we also take care not to bend the needle. Then when I position this, everybody holds these differently. I want a nice firm grasp, and also notice how I have it. I want to do it to where when I've got a hold of that needle, I'm going to make a dart-like motion for our patient. So this is important because a lot of the times when we go to inject, we're very nervous about hurting the patient. Think about this as a needle. We want it to pierce the skin. It's nice and sharp, so don't forget about that dart motion anytime you give an injection. So don't forget to dart. All right, so now I'm going to take my non-dominant hand. I'm going to plump up the skin or the site just to give me a landmark and also make it a little bit more comfortable with my patient and go and inject. All right, I'm going to go ahead and give your insulin, sir. So notice I darted. Then I'm going to inject my medication, and now I'm going to slowly remove it, and then I can release the skin. As soon as I've injected, I want to make sure to activate that safety mechanism immediately. Now, I'm using this on the bedside table. This way it stays away from me, my patient. Also, notice we heard that click. That's the best way to know that it's locked and safe. So watch this. That's what we want, so this doesn't slide down and we know the needle's protected. Then after that, we want to make sure that we make sure the patient's not bleeding. Typically with a subcutaneous injection, they don't need a Band-Aid. We are not going to massage the site, and then we want to provide privacy back. Thank you so very much. And then provide patient comfort. So let's take a look at the skill transdermal medication administration. So when we're talking about transdermal, this is going to look a lot like our patches. So particular patches you may use as a nursing student or apply as a nurse is going to be a popular one, nicotine patches for example. Your patient may be ordered that. Also, commonly we use pain patches to help with relieving pain in chronic pain patients. So this may look like a lidoderm patch, for example, or a fentanyl patch. So when we go give a transdermal medication, what are we going to need? First of all, the medication itself and also gloves to apply it. So let's take a minute to look at this specific medication delivery system. It's a really neat medication system for the reason that it's pretty no mess. You put on a patch of medication that usually adheres to the patient's skin. Also, this medication delivers a slow delivery of a certain amount of drug over a specific amount of time. So for instance, you may have a patch on for only 24 hours, or you may have a pain patch on for your patients or administer this that lasts 72 hours. So there's different variations of transdermal patches, but no, this is a really unique delivery system for medications. So before you go give that transdermal medication, what do you need to remember? Don't forget those 7 rights of medication administration. Really important we're giving that right patch to the right patient. So once we check those rights, we want to make sure we look at that application site and make sure that skin is intact. So some of these drugs in the transdermal system, if we put it on a broken piece of skin, can be very irritating to the patient. So make sure to assess the site itself. Now, when I apply a transdermal medication, I always wear gloves. The reason why I do this, there could be pain medication. There could also be something like nitroglycerin, which can help with chest pain on a patient. And I do not personally want to absorb that as a nurse. So if necessary, we may need to clean that site off using soap and water and really just kind of pat that area dry before we give the medication. That way it absorbs much better into the skin. Now at this point, we may need to perform hand hygiene and replace those gloves if indicated. Now we can open our patch itself and remove it, and note, each patch is a little bit different. We need to see the side that is supposed to be placed on the patient. So note that on your package. One key note to keep in mind about transdermal is once you put on a patch for a medication, typically we have to replace that patch. Here's a great example. Someone that's receiving a nicotine patch will be placed at maybe one day at 7 a.m. Now the new shift the next day, since it's a 24-hour patch, we'll need to make sure we find that patch from yesterday and remove it so we're not overdosing the patient on medication.
Document where the old patch was removed and determine a different spot for the new patch. The patches need to be rotated to prevent skin irritation and breakdown.
Taking a look at special considerations for a transdermal medicine. One thing we don't want to do with a transdermal med is to put it on skin that's not intact or broken skin. This can be really irritating to the patient. Next, we need to remember that transdermal patches typically have medication still in them. We do not put these in the trash. Let me repeat, we do not put these in the trash. Transdermal medications can come in the type of med such as fentanyl or maybe lidoderm or lidocaine, something like that, like a pain patch, and we do not want to leave these in the trash. These are supposed to be disposed of appropriately. We do want to keep note that, remember, remove that old patch before you put the new one on, because otherwise you don't want the patient looking like polka dots and having several patches all over their body. That just means all of that drug is getting absorbed to their system, and that is not what we want for our patient. So a great tip is when you do a transdermal medication administration, it's really a good idea to date and time that application so the new nurse knows when they come on shift that, oh, here's the patch from yesterday. This was placed on there. So that's really helpful in communication of care. Also, we want to take that patch and dispose of it properly. Now, every facility is a little bit different about this. We just want to remember we do not put that in the trash. So some of your facilities may say, because there's drug on that patch, that we want to take that patch and put it in something we call like a black box, for example, for proper disposal of that medication patch. Now let's take a look at how we obtain that blood glucose. So first of all is our portable glucose monitor. And again, this is going to vary depending on if you're in the hospital or at home or the monitor that the patient's using. We're also going to need our blood glucose test strips. So this is important because not any test strip can be used on any monitor. You have to make sure these are compatible. And next is the lancet, which is what's going to give us the puncture to obtain the blood glucose. And again, the lancets can vary slightly from facility to facility. You're going to need an alcohol pad for cleaning and some sort of gauze pad or even a cotton ball. So let's talk about how we obtain that blood glucose. Before we get started, we're going to perform our hand hygiene, provide privacy, and explain the procedure to the patient. You want to raise that bed to an appropriate working height and then position the client with their hand in a dependent position. We want to go ahead and perform our hand hygiene again and now put on our gloves. So this is the time to identify a puncture site. Many times this is going to be in the patient's finger, for example. Now here's an important note. We typically don't go in the middle of the pad of the finger. We typically kind of go around the outer edges. Now, occasionally we may need to dilate those capillaries and put maybe a warm washcloth or some sort of compress on there to help dilate those capillaries so we can get a good result. Now, what we don't want to do, and you may see in practice, is a squeeze really hard when we're talking about identifying a puncture site. That's not ideal because we can skew the results this way. So at all possible, try to avoid squeezing the finger tightly. Now we can go ahead and turn on that blood glucose on and select the client test. Then we're going to input the client's information into the meter. Now typically we can do this, especially if we're in the hospital, by taking the glucose monitor and scanning the patient's bracelet. Then we're going to input the information from our test strips in the glucose monitor. So again, this is typically by taking our monitor and scanning the test strips. Now once your monitor has identified the strips, we can insert the strip into the monitor itself. Then we can clean the site or the patient's finger with the alcohol pad and allow it to completely air dry. Do your best not to try to wave or blow on it here. Just allow it to completely air dry. Then we can use our lancet to puncture the identified site. Now here's the thing that many times students forget to do. Make sure you wipe away that first drop of blood using the gauze pad or cotton ball. This could be a contaminated sample and not the one we want to use for test. Now we can touch the test strip to that drop of blood. We've got to make sure the test strip area is completely filled. Now once that occurs, usually your meter is going to start running its results. We can apply pressure to the puncture site while the results are being processed. Now we're going to read the digital display when processing is complete. Let's take a live look on how we obtain a blood glucose sample from a patient. So I'm going to go ahead and do this on myself today and just talk you through this. And I've got my supplies here ready. So the first thing after we perform our hand hygiene, we've explained this to the patient, we want to make sure also we have the right patient by using our patient identifiers, the patient's name and date of birth. Then we want to go ahead and identify a puncture site, and many times it's going to be your patient's fingers. So today I'm just going to use this finger here. Here's the other piece of this, is when we do a puncture site, we're going to do our patient's fingers, but not the middle pad here. We're typically going to get maybe the soft, cushy side portion of their finger. Also note, if your patient's diabetic and have been poked a lot, you can see those little pin pricks, rotate sites as much as possible. So once we've identified our puncture site here, what we don't want to do is sit here and squeeze on our patient's finger. If we need to dilate those capillaries, we can put a warm compress on there if needed. Now we have a home meter that I'm going to use to demonstrate, but I'm also going to talk you through the steps if we were using equipment that's widely used in acute care or the hospital, for example. So I'm going to go ahead and turn on my blood glucose meter. Now, if I was using one in the hospital, we've got to make sure we've got the right patient. So on the display screen, you would see an option for a client test. So you would make sure you would choose that option. Then after we did that, we have to make sure we input the client's information. And again, if I was at home, this wouldn't be a problem. But if we're using this in an acute care facility, we want to input the patient's data, and typically this is going to be by taking the meter and scanning the patient's bracelet. So that's going to make sure to upload the patient, but of course, make sure you as the provider or the healthcare personnel verify the two patient identifiers, the name and date of birth. Now, once we've made sure we have the right patient, we've got to identify the strips to the meter. So we're going to input that information as well. It would be by the same method that we would take our meter and we would scan our strips, the barcode here. We've got to make sure these test strips are recognized by our meter. Now, once we've done this, we can go ahead and insert the strip. So once we insert our strip, usually it's got the piece here where there's a little bitty gray box. That's what's going to fill up with blood. That's the piece that should point outwards. The other piece is what's going to slide in our meter itself. Now, when you slide the glucose strip in, it doesn't matter which type of meter you're going to use. It will recognize that there's a strip and it's ready to go. You'll also know it's ready by seeing this little drop of blood, and that's common on most meters. So now that I've got my test strip ready, now I can go ahead and clean the site with an alcohol pad. Now, of course, I'm doing this all myself, but if I was in the hospital, I would be donning my gloves. So for this demonstration, I'm just going to do it on my own finger. So now I'm going to go ahead and take my alcohol pad, take the puncture site that I identified, and I'm going to make sure I clean this thoroughly. It's also important to allow this to completely air dry. Now just know each facility uses a little bit of a different lancet, so just know that. So this one, I'm gonna take this out. Make sure you get familiar with your lancet because again, each one of these are a tad bit different. So I just pulled off the stopper here. Then I'm gonna take my lancet, I'm gonna push it towards the pad and keep little pressure here. And then I'm going to push down the top. You're going to hear a click and puncture the site. So once you've seen this, you see that I've got a drop of blood here, which is great. So, and we don't want to squeeze too hard. I'm just going to squeeze lightly and make sure I wipe the first drop of blood off. Now this, as you can imagine, may have some of the alcohol from it from when we cleaned and dirt and debris. So we want to make sure we take off that first drop of blood. Now it's not a bad idea to make sure you have an ample amount of blood. It's okay to lightly, as you see, compress the finger, not squeeze, to get enough sample to fill our test strip. So here's the piece about the test strip. We don't want to lay this on top of the drop of blood. We want to take this to the blood and make sure that it fills up our test strip. Now, once we've done that, we will get our meter to read. It'll start reading for you. Then after we've done that, we can go ahead and apply pressure to the puncture site as the results are being processed. Now, once that's done, we can read the digital display, and then when the process is complete. And then just if you're at home, you may end up loading that to a certain device. So we'll put it into the patient's chart. Now, once we've completed this, we can remove the test strip from the monitor, discard the lancet and the sharps and supplies in the proper wastebasket, remove our gloves, perform hand hygiene, and of course, document the procedure. But once we've gotten this, we can remove our test strip from our meter. We can dispose of this, discard the lancet in the sharps box, our supplies into the proper wastebasket, remove our gloves, perform our hand hygiene, and of course, document the procedure. Now, here's a really important point to note before we go. It's important to know your facility's normal glucose ranges. If it's out of range, this may warrant that you contact the nurse, or if you're the nurse themselves, you may need to look for these results to see if they need prompt attention. Now, most agencies state that you need to get a baseline vital signs. So what I mean by this is before we even start the blood, you get a full set of vital signs, because if there's changes in this, such as hypotension or tachycardia, we need to know what the patient's normal resting vital signs are. Now, once we've obtained this set, we can assess the patient's respiratory and cardiac status again to get a baseline understanding of where the patient's at before we start the blood. Now we can remove our gloves, perform our hand hygiene, and then don new ones. Now, once we've donned our gloves, now we want to use the two-person verification process to make sure we're going to check that blood product and it's going to the right patient. So let's take a look at this verification process. As you can see here, there's a lot of points. Now, this is there to ensure safety, that we are giving the right type of blood to the right patient. Because you can imagine there's a lot of horror stories out there about all the blood incompatibilities. So this is there as a safety net for us to make sure that we're ensuring the safest process for the patient. So when we go to verify the blood, we've got to make sure those who are verifying it are qualified to do so. So this is typically going to be 2 RNs at the bedside. Now, it's important again that we're going to stay at the bedside with the client, so you've got to arrange your care to know that there's going to be intensive monitoring, especially when we first start the blood. Then we've got to ensure that we match the actual blood, that is the correct type and the right blood product for the healthcare provider's order. Now, once we've done that, we're going to verify the match between the name and date of birth on the client's actual wristband to that information on the blood bag that we got from the blood bank. Now, when we're checking this process, there's a specific blood bag verification number we've got to check, the blood type and RH compatibility, and we've got to make sure that that blood has not expired. Now, once we've gone through this verification process, then we can sign the transfusion form in on either paper or the electronic healthcare record. Now, once this verification process is actually complete, now we can actually prime the administration tubing, but we're going to prime it with saline first. Now, once we've primed it all the way to the end with the saline, we want to spike our blood product. Now, here's a tip for you. This is what I personally like to do. Sometimes once you spike the blood product, I actually like to spike the blood all the way to the end of the tubing. That way, when I start the transfusion itself, I don't delay if there's any potential for blood reaction. When I'm there with the patient and I start monitoring, I know the patient's getting the blood. So then make sure that you place the administration tubing into the infusion pump itself. And we want to use that alcohol pad to scrub the hub of the peripheral IV tubing. Now, don't forget, patency is important, so we're going to flush that peripheral IV with that 10 ml saline syringe. And we're going to check here that there's no irritation or leaking at the site, and that IV is patent and working well for our blood products. Now, once we've checked that IV, we can attach the administration set to the peripheral tubing. And then label, this is a good idea to maybe label the tubing near the client so we know quickly that that's blood. However, many times you can see clearly that this is the dark red, the blood that's going right to that site. Now, once we begin the infusion, many times you'll see policies say to use a low and a slow rate to transfuse the blood. This could be anywhere from about 30 to 50 mils per hour. We do this to slowly introduce the blood and check for any transfusion reactions. It's really, really, really important that once we start that blood, we stay with the client for the first 15 minutes and we do not leave that bedside. So this is really important because we've got to monitor for any of those transfusion reactions. So if you recall, this could be chest pain, shortness of breath, this could be fever, hives. There's a numerous amount of transfusion reactions, so make sure you stay with your patient. Now, after that first 15 minutes, it's really important to reassess the client's vital signs, their respiratory, and their cardiovascular status. Now, after that first 15 minutes, when we check that vital signs, if you remember, we could be looking for things such as hypotension, tachycardia, or fever, and that would indicate a possible transfusion reaction. And again, any of those abnormal signs, you need to stop the reaction. Now, every agency is a little bit different, but it's pretty standard that after the first 15 minutes that you initiated the blood transfusion, you check vital signs. But the frequency thereafter is very specific to the agency protocol, so make sure that you check yours. Now we can increase the infusion rate as prescribed and as the patient tolerates it. Now, one more thing to note, stop the infusion, again, if any of those signs of reaction occur, but don't forget to check the IV site because infiltration, leaking around the site, or pain can occur at the IV site with blood administration.
Now, before insertion, let's look at a few key points. We always want to remember to perform our hand hygiene, provide privacy for our patient. So I will tell you, this is not the most pleasant procedure when you insert a nasogastric tube. So you want to make sure you provide the patient as much privacy and comfort as possible. And really be thorough about explaining the procedure to the patient. As a nurse, be honest. Let them know, hey, this is going to be uncomfortable and this is what's going to happen. Now next, we want to raise the bed to the appropriate position. We also want to make sure we help the client to an upright position, so about at least 45 to 90 degrees. Now, the higher the bed, the easier the insertion is going to be. Also, get a baseline idea of what the patient's GI status is going to be and how they feel before you insert the NG tube. What you're going to need is your nasogastric tube, and so you're going to have to choose here depending on the need for your patient. So here we have a Salem sump, for example. You're going to need an absorbent pad or maybe a towel, and also a securement device. Now, it's really important that any time that you put something into a patient, like insertion of a Foley catheter or like a nasogastric tube we're doing here, you want to use a water-soluble or lubricating jelly for comfort for your patient. We want a clean piston syringe. And we're also going to need a cup of water if it's not contraindicated for a patient. So this is important because we're going to help use this to help the patient swallow for advancing of the tube. So before we get started, we want to perform our hand hygiene and put on our gloves. Now next, it's really important to assess the client's nasal cavity. Now this is important because maybe your patient has some facial trauma, or maybe they have a deviated septum. So we want to look at each nair and to see which one is best to attempt to insert our NG tube. Now we've got to determine the insertion length of the NG tube. You're going to take the tip of that nasogastric tube, put it to the tip of your patient's nose. Then you're going to stretch it across to their earlobe and then all the way down to their xiphoid process. Now, just for safety, I usually go a few centimeters past that xiphoid process. It's really better to go a little long than to be short. Now, after we've done this, we can drape an absorbent pad or maybe a towel over the client's chest. Then we want to make sure we lubricate the tip of the nasogastric tube. This is going to be really key to help with insertion and make it much more smooth and comfortable for your patient. So once we've lubricated the tip of our nasogastric tube, have the client position their head straight forward. So then we want to take the distal tip of that nasogastric tube and insert it into their nostril. Now once that's occurred, you want to teach your patient to position their chin to their chest like so. So this is really going to help advance that tube past the back of the mouth into the throat and not into the trachea. Now once we reach to the back of the mouth, we can then have the client swallow through air or take a drink of water and help swallow to facilitate the movement of that tube further down the esophagus. Now this is really key here. If the patient begins coughing or if the tube coils in the back of the throat, we need to stop the procedure. Now here I like to take a pen light, for example, and look in the back of a patient's throat, making sure that if it coils or if I catch that early, I can stop the procedure for the patient. Now, if it goes smoothly and there's no coughing or no gagging, we can continue to advance that nasogastric tube to the predetermined length. Now, one thing to know when advancing, if you go really slow, it's just really dragging on the procedure. So if that nasogastric tube is going down, go quickly and keep going, advancing the tube. Now once that's done, you can secure the tube using a securement device of whatever your agency has to the correct insertion length. So once we've secured the tube, we want to confirm the tube placement by aspirating gastric contents with our piston syringe. Next, we need to obtain an order for an X-ray to verify the exact placement and positioning of our nasogastric tube. I'm going to show you how to insert a nasogastric tube. So before we get started, I'm going to perform my hand hygiene. All right, and I'm going to go ahead and put on my gloves. So one thing to note about nasogastric tube insertion, because we're through the GI tract, this is not a sterile procedure. I know you may see some things that are in a package, but just again note, the GI tract is not a sterile environment. So this is helpful for you to know as a student. And at this point, I've already explained the procedure to my patient. I also let them know that when you insert a nasogastric tube, it is not the most comfortable procedure. So be really honest about this when you're approaching your client about it. All right, so next let's go ahead and assess the client's nasal cavity. So when I do this, I'm going to look at each nerve or patient. You can even take your pen light, for example. Take a look up there. Ask the patient if they have a deviated septum or any issue on one side or the other. The other thing you can do is have the patient close one nostril and blow and see which one has a stronger airflow, for example. So once we've assessed the patient's nasal cavity, I'm going to determine the insertion length of our nasogastric tube. All right, so let's take a look at the equipment that we've got here. I've got a little tape for marker here. I've got our lubricant. I've got our piston syringe. I've also got a nasogastric securement strip, our nasogastric tube, and I'm using the Salem Slump today. Also my pen light for zip visualization, and sometimes if you need to look inside the patient's mouth, it's handy to have maybe like a tongue depressor so you can push down their tongue and take a look inside their mouth. So if you have some help, anytime you place a nasogastric tube, it's always great to have a second set of hands. Okay, let's take out our nasogastric tube. So I want to show you a few things before we get started. So you're going to see this tip of the nasogastric tube. So this is our distal tip. The other thing I want to show you is here is that air vent port that we talked about earlier. Now this piece here has our little bit adapter. And this is here to put suction down, for example, or hook to suctioning. We also can put our piston syringe here for feedings, medication delivery, for example. When we're using a Salem sump tube, the smaller blue lumen serves as the air vent. We also call this an air vent or the pigtail. The air port allows for an inflow of atmospheric air, which prevents a vacuum if the NG adheres to the wall of the stomach. Now, when I said that we weren't going to do anything with a smaller blue air vent, what I mean by this is that we don't connect that air vent to suction or use it to flush liquids or put anything down that air vent. A great pro tip is that the blue pigtail or the air vent should be positioned above the level of the stomach. This is going to help to avoid backflow of stomach secretions. Now, many times we're going to use an anti-reflux valve, and this is attached to the blue pigtail to prevent gastric contents from spilling out. Okay, and remember, I've got clean gloves, this is open, this is not a sterile procedure. So I've got my nasogastric tube here. Okay, so now we've taken a look at our tubing. Let me show you how to measure. So I'm going to take this distal tip here and I'm going to take it to the tip of the patient's nose. So we're going to take it to the tip, we're going to take it to the side of the earlobe, and then I'm going to take my measurement and go down and feel and palpate where his xiphoid process is. And if you want to, it's always a good idea just to go a few centimeters over. The reason why I do this, like I spoke about earlier, is that it's always better to go a little farther down because that's much less risk for aspiration. Okay, so a couple of tips once you measure the length. It's really important for you to mark this. So every nurse has a preference. You can use a black marker is a really great idea, a permanent marker. That way we know exactly where the insertion piece should be. Also, another little tip, if you will take a piece of tape on insertion and you wrap it around where the insertion point should go, doesn't have to be neat, then when you're inserting, you know exactly where to stop. So this is really helpful in the meantime. And obviously, once you're inserting, you can take this off as well. Okay, so now that we've measured this, we're ready to go. So we've got the measuring of this. The other thing is I want to make sure my client is comfortable. Notice that the patient's head of bed is up at least past 45 degrees. If they can tolerate it, 90 degrees is even better. The other thing is know that there's secretions. We're going to be going down the nasal cavity. So I'm going to protect my patient as well and put absorbent sheet over him. That way if they cough or sputter or anything like that, we don't get it on their gown. Okay, so now that's set. So now I'm going to prepare my equipment. And I'm going to lubricate the tip of my nasogastric tube. So you may see a nurse lubricate, like stick the tube down into the surgical lubricant, but I just want to be extra nice as a nurse and make sure this is really well lubricated. This is going to help for much more easier advancement, if you will, to the tube. And I'm just going nice down the tube and make sure that's nice and lubricated. May seem a little excessive, but it definitely helps provide comfort for your patient. Okay, and before I start that, I'm going to go ahead and get my nasogastric strip ready. This is going to help secure it when I'm ready. And once I've placed the nasogastric tube. Okay, and you're going to see why that's important here in a bit. Okay, so I think we've got our lubricant, we've got that ready. Okay, so now I can go ahead and insert. So again, I've explained the procedure to my patient. So when I do this, I want to make sure my patient's head is tilted forward. It's never a bad idea to put your hand behind the patient sometimes. They're going to naturally resist you when you insert the nasogastric tube, but I don't think this guy's going to resist me much. All right, so here's our nasogastric tube. I'm taking the tip, and I'm going to go down this nair. So once I insert and I start feeding it in, this is a good time to have the patient chin to chest. So I'm going to move his chin to chest, and then I'm going to advance the tube. Because remember, we're trying to make sure we get down to the back of the throat. And we're going to advance the tube. So notice I'm going in a very pretty smooth situation, right? I didn't take too slow, it advanced smoothly, so I'm going to keep going. Now you see here why I like to mark that tube, because without having to watch, I can just keep going if my patient can tolerate it. Now, here is what I like to do before I lose my tube. I want to secure it. So this is where the nasogastric tube comes in, or the securement strip, excuse me. The little heart's going to go around their nose. Take off the securement strip and my measuring tape. So notice the whole time I'm doing this, I've not let go of the nasogastric tube. And the reason why I don't want to do this, I don't want to lose placement. Okay, so now I've gotten that done. I'm going to place this on top of my tube and I'm going to wrap the wings around. Okay, so now this is secured. So again, this is why I like to secure my tube first, because then I can check on my patient, I can make sure and look at them, make sure everything looks all right. And that way when I check for placement, I'm not having to fumble around and not lose my tube. Okay, so now that I've done this, the next thing that I can do is check for gastric contents and make sure it's in the right place. So when I do this, I'm going to take off my filter. Now your hands may be a little slippery from the lubricant. I'm going to insert my piston syringe, and then you can pull back, and when you do, if it's in the correct placement, you're going to see gastric contents come through here. Now, one rule of thumb, anytime you remove gastric contents for an NG tube, you want to replace those. That's your patient's normal bacteria, flora, and you want to give it back to them. Okay. Okay, so that's one way to verify. Then we want to go by our agency protocol and get a chest x-ray and make sure it's in the right place. So one key note I want to talk about while I was advancing. Clearly this guy went pretty smooth, but as I'm advancing, if you have a helper with you, it's a great time to have your helper. As soon as I went past the nostril, I'd like to take a tongue depressor, push down the patient's tongue, and pin light in my patient's mouth. So as soon as we go past the nair and we go past the back of the throat, we can assess and make sure that tube is not coiling in the back of the patient's throat. Now, during this procedure, if my patient were to cough or to gag, I need to stop immediately, assess where maybe the tube is, and stop the procedure and maybe even pull out. So if we need to do that, that's totally fine. You just want to take a rest, make sure your patients are comfortable, and then reattempt again. Now, anytime you're inserting nasogastric tube, if you meet a lot of resistance, you want to stop. You may need to try the other nostril on the patient to see if it's a little bit smoother. Now, before the irrigation step, here's a key time to assess the wound. If indicated, we can measure and document this appropriately. Now, before we start, let's go ahead and put on our gloves and prepare our irrigant fluid. We want to take the irrigant, and this could be whatever's prescribed by the doctor. Typically, it's going to be normal saline that's sterile. We're going to pour this into our irrigation container. Now we're going to take our catheter tip syringe to withdraw the irrigation fluid from the container. We're going to take that syringe and irrigate our wound. Now, if you take a look at this image here, notice that the tip of that catheter syringe, or the tip of this syringe, is not touching the wound. That's important. Also, I just want you to keep in mind when we irrigate the wound, you want to go from the clean areas, which is typically going to be the wound bed itself, to the dirty areas until all the areas are cleansed. Also, just know when you're using this syringe, be gentle. Not a lot of force with the catheter syringe or on the plunger. Be gentle when you're irrigating here. And while we're irrigating, we're going to allow all of that fluid to be caught into the basin that's below the wound. Now, you may need to repeat this step a couple of times if indicated. Then we can discard the syringe. Now also, just know around the site, because there's a lot of irrigant fluid, it could be moist, we can take our sterile gauze and dry the patient's intact skin and the skin around the wound. If indicated, we may want to put skin protectant if ordered and apply the wound dressing as ordered by the physician. Okay, so now that I perform my hand hygiene, this is a great time to assess the wound. So a couple of things to know is we want to look at the wound bed, we want to look at the edge, we also want to take a look at the skin around the wound. That's also important. The other thing to know is that at this point, depending on the order or if you're tracking the wound, many times we're going to measure it at this point. So I want you to take a look here. So because I'm going to measure, I'm going to go ahead and put on my gloves. And many times you have cotton tip applicators that are sterile on your unit. This is a great device to use because it's sterile. Also, I want you to note that there is a measuring guide on top of here, so it makes it really easy. Now, sometimes there will be just a separate paper tape that's disposable that your facility may have, so you can grab that as well. But if you can't find one, there's one here on the cotton tip applicator for you. So when we go to measure a wound, and I'll just quickly talk about this, we'll open this up. We're typically going to do the length, and this one's pretty long, right? We're going to take this and compare it here. We're going to do the width, and then we're going to do the depth. When you do the depth, you're going to go to the deepest part of the wound. Then we're going to see what's flush on top of it. Basically, I'm going to put my fingers where where it opens on the skin surface here and flush to the skin surface and then compare it to my guide. So when you're assessing the wound, you would do, for measurement, you would do length, width, and depth. Once we've done with this, we would note our measurements and then document those. Let me go ahead and get rid of this. So once I've done that, we can go ahead and pour irrigant solution into the canister. So I've got this really handy irrigation tray here. I'm going to move this a little bit out of the way. So the nice thing is with this has got a container here for me, and my catheter syringe is in here to withdraw the fluid. So I'm going to take my sterile saline, open this up. So I'm going to go ahead and pour this into the container now. Okay. So then I can just leave my syringe in here, and that way it keeps it clean and it's handy for me. Okay, so now that I've got this, I've got my irrigant fluid poured. I'm going to take my catheter tip syringe and pull up my fluid. And as you can see here, I have ample fluid for irrigation. Now, I'm not going to show you today. You kind of get the general gist, but we'll talk through the irrigation. So when I'm irrigating, I'm going to go the cleanest area to the dirty. So typically that's going to mean I'm going to irrigate with a wound bed, then we're going to go around. Now here's a tip when you irrigate is when I'm pushing down on the plunger, the faster I push down, the more force that's going to go into that wound, and that can be really uncomfortable. So a good tip is just to gently push down and see how the patient tolerates that. And again, you may have to repeat this as necessary. So again, using the syringe, you're going to go the clean areas to the dirty areas until all of those are addressed. So if I was using a basin, all of that would fall into our basin for us. And again, you may need to irrigate a few times. So once I've done this, I can discard my syringe. Then I'm going to take my sterile saline, my sterile gauze. And because my wound got a little bit wet,
we're going to take our gauze and we're going to pat dry the skin. What I don't want to do is scrub because that could mess up the integrity of the wound. So I can take one, discard, and then just use as many as needed. Now, once I've dried all of this, sometimes there may be a physician order for certain skin protectant that needs to go around the skin of the wound. So just keep that in mind. Now, once I've done irrigating, this is just me. It's just a great idea since I've been kind of irrigating and my gloves can get wet. I'm going to go ahead and change those now and perform hand hygiene and put on some new ones. I like to do this because I'm touching clean supplies now. Okay, so I'm going to take my dressing, going to open this up, and I'm using an ABD pad. So when I open this up, be conscious not to touch the inside of the dressing, and I'm going to put this flat. So good thing here is once it's covered, we're pretty safe. So sometimes it's hard to handle tape or things like that or the dressing, but as long as you're covered here, we're good to go. So one thing I want you to talk about, we love these ABD pads as nurses because they're a little bit more absorbent, and the blue line goes to the sky. And the more absorbent piece is on the wound. So just keep that in mind with these. These are called ABD pads. And actually, in fact, we do use these a lot for abdominal wounds because they're much bigger and they're absorbent. So once I've done this and I've applied the wound dressing, now's a good time to go ahead and secure this. So I can go ahead and take my tape. What we want to do is a window type dressing. So I'll show you how to do that. So also just keep in mind that when you are taping this down, every patient has different allergies. So I'm using this plastic tape. If your patient has adhesive allergies, note that as well. There's different options we can use. So as you see when I'm doing the window, I'm just tearing pieces and truly going to each side to enclose that. Now clearly this is kind of an odd shaped wound. You would have much more body surface to do on a patient, but the whole point is to make a window with the dressing in the middle. If you can minimize the amount of tape on the patient's skin while also securing it down is ideal. You can imagine how much tape can get on a patient's skin when we keep having to change the dressing. Okay, so we would tape this down in a window-like fashion. Again, you would go the bottom, top, sides, or whichever order just to make a window here. Now, before you leave, don't forget, like we've seen earlier with the previous shift, to make sure that you initial, then you're going to date, and you're going to time your dressing. Because when the new shift comes on, then they'll know when the last dressing was done. Once we've completed irrigation, we want to go ahead and dispose all of the soiled equipment, assist the patient back into a comfortable position, place the bed to the lowest position for safety, remove our gloves, perform our hand hygiene, and don't forget to reassess the patient's pain. That procedure, again, could be a little uncomfortable for the patient, so make sure you reassess and treat accordingly. And of course, don't forget to document. Let's look at a few considerations regarding wound irrigation. So there's some possible complications that can occur. Anytime you expose the wound, there's increased risk of infection.
And of course, we had talked about when you irrigate, some of that forcing of fluid inside the wound can increase the level of pain for your patient. And don't forget to assess that skin that's surrounding the wound. We call this peri-wound, and this could be excoriated, red, and uncomfortable. And again, let's look at these points, these considerations that's really important when you're talking about wound care. Now, irrigation solutions are great, but they're usually a part of wound care orders. Most of the time, this is going to be sterile normal saline, but make sure you assess, check your physician's order, because this could vary. Now, here's a really important topic, and sometimes this gets students confused. If we need to culture the wound, meaning that we get in there and we take tissue and we send it to lab and check to see if there's any sort of infection going on, or if it's growing something odd we need to treat, we actually want to cleanse the wound first and then get the culture. That may seem kind of backwards, but if you think about it, if you've got an open wound, sometimes there's some extra stuff in the air or bacteria or microbes. That's not what we want to test. We want to test actually the wound bed, so we want to cleanse first and then culture. So don't forget that point. Now, a few more points here, and we've talked about this a little bit. Wound care can be very painful, so again, make sure you treat accordingly and pre-medicate if you're able to. So one of the last considerations to keep in mind, some healthcare facilities have an excellent wound care team. These are nurses that have advanced training in the treatment of wound care. Thank goodness for them. But many times they're going to be the ones that track the progression and the healing of the wound. So because we don't want those wounds exposed to air any more than we have to, make sure you coordinate with the wound care team. Now, when we're talking about ostomies and nursing care, really there's some really important pieces post-operatively and for established ostomies that we need to be aware of and talk about. So when we're talking about care for an ostomy, we need to assess the stoma, we need to provide really good skin care, also how do we empty the waste pouch, and also how do we even change that appliance. Now, there's quite a bit of pieces for each one of these, but I'm going to take you through those. Now, let's start first with assessment. As nursing, we always go back to assessment, right? So there's quite a bit of points here, but let's talk about why these are so important. Now, with a stoma, there's a lot of things can arise, so let's take a look at these. Now, at least once per shift as a nurse, you should be assessing that stoma, and here's some things we're going to look for. So we need to look for skin irritation. So if you take a look at that upper stoma with that red ring around it, really if you think about it, any stool or feces or urine that gets on the patient's skin can cause really bad redness and irritation. You can imagine, just like your hands in the winter, if there's dry, cracking, redness, it's really painful and not good for the integrity of the patient's skin. Also, leakage can occur. Same sort of thing here, to where if stool or feces gets on the patient's skin and it leaks around, that can cause issues. Now, sometimes that may be happen because of the way the stoma was created surgically, or maybe the appliance that we use to catch the feces is not fitted very well. So that's something that we can prevent. Now, let's take a look at this picture here. You see that black picture? Okay, this is not what we want, guys. This is a really big issue here. So we need to make sure we alert the surgeon or the physician about this. This is called necrosis. Now, if you remember in nursing, when you see anything that turns black, this is a big no-no. What that means is there's not good blood flow going to this part of the intestine that's on the outside of the abdominal wall, and that's a serious issue. So if we see a darkened black stoma, that is a serious issue. So let's take a minute. What should the stoma look like? Let's just refresh. If you remember seeing those pictures earlier, it should be pinkish or red, nice and round, and it shouldn't look like any of these pictures, right? Now, the other thing that can happen with a stoma, Man, I know there's a lot, right? We're almost halfway through. So there can be some blockage here, and that's an issue because your patient's going to feel increased pain, maybe a lot of nausea and vomiting. The stoma itself could start getting really swollen or edematous. If you see this, you want to alert your doctor. The other thing that can occur is stoma prolapse. Okay, this is a little scary looking, I know, as a nurse. If you take a look here at this picture, see how that stoma is long, that piece of the intestine is protruding out? Okay, yes, this could happen. Now you may think, okay, well, how on earth is that going to happen? Well, anytime there's maybe really increased abdominal pressure, maybe the patient tries to lift something heavy, kind of think of like a herniation or a hernia. Or if maybe the opening around the stoma is too large. This could all happen, and we call this a stoma prolapse. Now this is particularly, this actually comes up quite a bit with pediatric patients because they kind of have a weak abdominal muscle tone. Now lastly, stoma retraction can also occur. And what do we mean by this? So anytime you hear the word retract, right, we kind of think of it, maybe it back up. So what you're going to see here is the stoma, because there may be a lot of tension on that stoma, maybe because of how it's surgically created, the stoma can maybe recede inside the abdominal wall, and this is also an issue. This could be because of obesity or maybe lack of blood flow. And so guys, I know that was a long list. There's a lot of complications, unfortunately, that can come up with assessing the stoma, and there's even more. But the good news is some of these can be conservatively treated. Now, if conservative treatment fails, then they may have to get surgery again to correct this. Now let's talk about skin care. This is oh so important when we're talking about care for an ostomy. Kind of like we talked about earlier. We don't want that irritation that goes around the stoma because this can be really painful for the client. Now, when you're thinking about skin care, just think of with ostomy. Guys, less is more. Think about it like taking a bath, something like that. We're usually going to use really mild things here. So less is more here, and water is really actually usually sufficient for cleansing the skin. However, sometimes if feces gets on the patient's skin, for example, we may need to use a mild soap. Now, when I say mild, I really mean mild. We don't want something with a lot of lotions or fragrances or anything like that, even though we may think, okay, well, wouldn't that be good for the patient's skin? That actually could cause more irritation and issues. So again, mild soap is great. Now, again, things we don't want you to use around what we call peristomal skin or skin around the stoma are things like creams, lotions, powders are a no-no, alcohol pads like we like to use for cleaning for nursing because it can dry out the skin. Any sort of like steroidal ointments or creams, that's all a no-no in ostomy care. Because the reason why this is a problem, this can affect how the actual appliance that catches the urine or the feces adheres to the skin of the stomach. And lastly, when we're talking about skin care, there should not be any signs of irritation like you recall from earlier. So really, frequent assessment is key. And now anytime that you see, remember that red or broken or irritated skin, make sure you alert your doctor or make sure you follow up.
Welcome to preparing a sterile field and sterile gloving. So in this skill, I'm going to show you how to prepare a sterile field. Now this is going to be used for lots of common nursing procedures, inserting a Foley catheter, for example. Then I'm going to show you how to add sterile items to that field and also how to sterile glove. So before we get started, we've got to open our sterile kit. Now this will turn into your sterile field, and I'll show you that shortly. Now before we take off, I want to talk to you quickly about clean versus sterile equipment. So when we talk about clean equipment, this is going to be something you're going to use in routine care, for example, like just gloves that are typically placed on the wall in your patient room. This is for routine maintenance care. Now, when we're talking about sterile equipment, this is something that's typically encased in a package. Now, we do this because we want to reduce the amount of microbes or organisms that gets to the equipment. So we're gonna need our sterile kit, number one. Then we're gonna need like a hard table or hard surface, typically your bedside table we're gonna work from. Now, before we even get started, when you get your equipment, you wanna make sure you inspect it closely. So we wanna look for any wetness, any soiled marks. We wanna make sure there's no weird tears or openings on that package or the package is damaged at all. Then we want to make sure that it's in date, that the expiration date is still good. So just think about it this way, you don't want to eat spoiled or expired food, or most of us don't anyway. But when we are using equipment, expiration date is really important because that's going to make sure that equipment is safe and effective for a patient. And lastly, on most equipment, there's going to be some sort of enclosure, maybe like an intact sterile tape. We want to make sure this is still sealed. That way we know that the equipment is still sterile. So when we open a sterile kit before any procedure, we want to do our hand hygiene. Then we want to remove the plastic covering of the package. And then we want to make sure we place that package on a clean, dry surface. This may seem like a no-brainer, but in the hospital, these bedside tables are used for eating for patients, all kinds of things. We want to make sure that where we are going to lay our sterile field, it's nice and clean. Next, once we open that kit, we're going to take the top flap and we're going to open that furthest away from our body. Then there will be two side flaps that you're going to see, and you want to take one side flap, open that outward. Then we're going to take the next flap we see on the side and also open that outward as well. Now lastly, you're going to take the final flap and take that one, open it towards your body. Notice even in that motion, I move back a little bit. We want to be conscious not to lean over a sterile field. Let's take a look at opening our sterile kit. So if you remember, before we get started, we want to take a look at that equipment and make sure it's safe to use. So first of all, take a look at your package. Make sure it's not wet, it's not soiled, the package itself is not damaged. Then we want to remember to check our expiration date. So this is really important on use of patients because if it's out of date, we cannot guarantee that that's safe to use on a patient. Also, some sterile equipment, for example, may have like a sterile tape like this. If it does, make sure this is intact and not opened. That way we can ensure sterility of the equipment. Now, once we've inspected our package, let's now open our sterile kit. And first, we're going to perform our hand hygiene. Now, once we do this, we can remove the plastic covering of the package. We're going to have to take off this intact tape here and peel this open. We're going to remove this package from the plastic covering and open this up. And we can get this out of our way. All right, so once I've got my package open, I'm going to take this top flap. I'm going to grasp the outside of this and open that flap first. Now, before we get started, one thing to keep in mind, you're thinking, okay, this is a sterile item. I don't have gloves on. I'm touching the outside. So why this is acceptable is because this outside portion is what's going on the table and not used on our patient. All right, so let's look at this top flap. We're going to grasp this and open this away from our body. So one thing to remember about sterile kits and these fields, it's really tricky because sometimes this will try to, flap back open on your sterile field. So a little trick I like to do is take these corners and fold them kind of on the outside and curl them so they don't flop back this way. The other thing you just saw me do is touch the outside. We'll talk about that in just a second. So once I've taken the top flap and opened it away from my body, there's two side flaps and I'm going to take each one and open those. So I'm grasping the outside of the package, opening this up, and I'm curling these underneath themselves so they don't flap backwards. I'm taking my next flap and opening this as well,
And this can be tricky, as you can see. So notice I'm touching these edges and really trying to make sure these curl down. Then I'm going to take my final flap and I'm going to open this toward my body. Now watch when I do that. I'm going to move away because I do not want to interrupt my sterile field. So now this is open, a trick I want to show you. It's really important that we have this in the way that we can perform our patient care. This isn't ideal, so I can take the edges and move this appropriately or move it side to side. Now, a really important concept with sterile field. Well, there's a few. First one is, notice you saw me touch that and you're thinking, I thought you weren't supposed to do that. But you have a 1-inch border on a sterile field that is acceptable to touch. So again, you have a 1-inch border around the sterile field that is not considered sterile, and we can use this to move our package if need be. So let's say I need to move it up my table. I can touch this 1 inch and maybe move it forward or back or wherever I need it. Now that this is open, I cannot touch anything inside this sterile field and anything inside this 1-inch border because everything inside the package is sterile. And remember, I don't want to leave this and I want to maintain eye contact on it at all times. Welcome to the skills video of how we perform a head-to-toe assessment. Now, I'm a practicing nurse and I would love to show you how we do a systematic method of going indeed from head to toe to perform an assessment on our patient here with Brandon. Now, we're going to show you skills on how to move through this assessment. But just note, we're not going to go through each and every assessment detail. Now, we have specific resource videos for you to refer to. Now, a couple of things to remember. Now, when you're learning an assessment in nursing school, now often you hear instructors and during your health assessment course segment everything such as neurological and then musculoskeletal and then cardiac. But really, in real practice, many times I just do this all at once and again in a systematic fashion from head indeed to toe. Now, in real life, you're going to be asking questions as you go and you move from head to toe with your patient. And again, this is not going to be shown here, but this is referred to in other assessment videos. As I begin my head-to-toe assessment as a nurse, one of the first things that we do before we start our assessment is when I enter into the patient's room and before I start assessing from head to toe, make sure you introduce yourself. And it could just look something like this. Hi, I'm Samantha. I'm going to be your nurse today. Can you go ahead and give me your name and date of birth?
Brandon,
Okay.
March 7th.
Okay, perfect. And would you like to go by Brandon or Mr. Smith? Do you have a preference?
Brandon.
Brandon, okay, perfect. So just by doing this, I'm just making sure I involve my patient and what their preference is with our care together. Also, Brandon, can you tell me what day of the week and what brought you in the hospital? Why are you here?
It's Monday. I was in a car.
Perfect. Oh man, okay. So then here we're assessing our cognitive status very quickly with our patient. Now, it's a good idea during this step as well when we're talking about assessment is just let Brandon know that he may need to participate during the assessment, and as a nurse you want to watch and listen and look for the responses from your patient. Now, formally, as you can see in that very quick interaction, I can see as I walked into the room and even before we started that I could see Brandon sitting upright, he's awake, he's alert. And during our quick conversation there, I already could see that Brandon is coherent, he's accurate in his information, and he's able to quickly and verbally respond. Also, at any point, if Brandon wasn't really very awake or alert, he wasn't with his eyes open, then that would be a good time to see if Brandon can move his extremities or maybe grasp my hand, or if he's withdrawing from any sort of pain, if he wasn't in the same cognitive status as you see here as awake and alert. Now, as I start my actual physical assessment with my patient here, we're going to start indeed at the top here at the head. Now, as you can see, I'm going to take just a quick scan of Brandon's face, his head here, and check all of those important points.
such as just looking at his hair, I can see it's clean, it's healthy. Also, don't forget that if your patient has any sort of device, such as a breathing tube or oxygen, which is really common, make sure that you check those point of contact. This could wear down the skin and cause ulcers, so we want to make sure we check that. The other thing to keep in mind, now if you remember, Brandon came in with a motor vehicle accident, so we want to be diligent in checking. Did he have any bruising or lacerations, or did he look like he had any breaks? And lastly, don't forget about the coloring just of the lips and the skin. Now, as you can imagine, if I walked in and Brandon looked really pale, or if his lips were blue, this is a bad sign that he's not getting appropriate oxygenation. Now that we've assessed the general appearance of the head on our patient, next I'm going to move with Brandon's eyes. So here is where we assess what we call the pupillary response. So this is where we get to use the fun part, that pin light that you're always asked for nursing school. Now this is actually going to be really helpful on certain traumas or any neurological floors or neurological patients. So one of the things that we actually use is what we call a pin light. So this is really helpful because it's important to note the size of the pupils. Now we're actually going to note the size of the pupils and compare them to our guide when just the patient's at rest with no certain light in it at this point. Now really what we're just using this light for is to make sure that when I shine the light in Brandon's eyes that both of those pupils constrict. So it's going to look like this. So I'm just going to take my pin light. I'm going to push down, and just by looking at Brandon, I can get a good idea about what his pupil size is. Then I'm going to take my light and illuminate it, and I'm just going to have, Brandon, will you look right here for me? Perfect. So I'm going to take my pin light and guide it down one pupil. Now when I do that, I see that when I bring the light here, both pupils constrict, and then I can repeat it on the other side. We're just looking for that bilateral consensual pupillary response. The other thing we look at for eyes is he tracking? All that means here, and as you can imagine, when you walk into a patient's room, their head and their eyes are following you around. That's an easy way to assess tracking. Now, there's some variations when we're talking about pupil size and things like that. There can be a lot of abnormalities that need to be reported. Now, once we've assessed Brandon's eyes, we're just going to move down and look in the mouth. So this is actually really underestimated. I find it very important as a nurse to assess a patient's mouth. In particular, I used to take care of stroke patients, and many times there's a lot of different bacteria or fungus back there that makes it really hard for swallowing. So we're going to check for deformities. This is a great time to pull out your pin light again, and I'm going to take this. And Brandon, will you open up your mouth for me? Great. So I'm just going to look through. Perfect. So when I assess Brandon's mouth, all I'm really looking for is dentition. Is there a lot of lacerations or redness or swelling on Brandon's lips, his tongues, and the back of their throat? I'm also looking for any white that could be any sort of thrush or an infection, for example. Now, is there something in the back of his throat that sometimes gets caught up and hardened, and then it makes it hard to swallow? And it's also important to note the cleanliness of his mouth and teeth. Now, after we move past the mouth, now we can go through the throat. And as I was looking down there, I was assessing the mouth part, but when I'm looking just from head to toe, when I look at Brandon's throat, what I'm really looking for is that tracheal-wise, down the middle is for alignment. I don't see any abnormalities. This is a good time as well when you're talking to your patient and have them naturally swallow, just see if there's any abnormalities or difficulties. And sometimes on your assessment, depending on what you're looking for, it's also appropriate to palpate for his carotid pulse. So where we would do this is, and during the CPR cycle, this may be a time that you do that. So if you go about midway between the middle and the front of his throat and use your fingers and palpate for the carotid pulse. So it's really important here that we're not pushing down really hard and restricting blood flow. So now that we've gone head to toe, And don't forget, all while I'm doing this visual scan, I can see Brandon's ears, any odd drainage or anything like that that we can assess as well. Now, once I move from the head down to the throat, this is a great time, as I've been working through my assessment, to check the chest of our patient. So we're going here and we're moving down. Now, during this time and throughout this assessment, I can look at his rate, the quality of his breathing, how deep he's breathing. We want to look for some key things. So Brandon looks like he's resting comfortably, breathing easily, but if I saw Brandon breathing fast and labored and having difficulty, that's important to note. Also think about that if you see his retract, any sternal retractions, that's also abnormal. So one thing just to think about how you breathe when you're relaxed and easy. That's what you should see here on your patient like Brandon. Now, when you're talking about the chest, depending on any kind of surgery they may have had, you need to double check as well that is there any chest tubes, any sort of drainage tubes coming out. If that's the case, we definitely have to look around the insertion site and see what's the color of the drainage going through the tube. What about the insertion site? Is it red? Is it swelling? Is there any sort of pussy type of things coming out? If that's the case, definitely need to check that as well. Now, if Brandon here specifically had a chest tube, for example, we need to make sure we look around this and palpate for what we call is crepitus, meaning there's bubbling or some edema and some excess fluid under the skin around that tube. Now, if that was the case, this is also abnormal and we need to report this. Now that we've talked about the general assessment of the chest and the observation, now we actually get to use our ears. So when we do this, we call it auscultation of the lung sounds. So anytime you hear that word in nursing school, auscultation, it means to listen. So here's a really important point to note, and many times you're going to see nurses do this, but it's really important to listen to the front of our patient's chest, Brandon here, and also the back. Now we're going to do this because sometimes you can't catch stuff in the front, and you may indeed hear abnormalities in the back and the bases of your lungs. Also make sure you compare side to side. So you want to know when you're listening, is there anything crackly sounding, kind of like Rice Krispies, or any sort of like high-pitched abnormal sound like asthma. Anything abnormal you want to document and also report. Now I'm going to show you how we're going to auscultate the front and the back of Brandon's lungs. Now just for this demonstration, we're actually going to listen over the gown, but just so you can see where I place my stethoscope. Now as you can imagine, if I listen around here, you can imagine when you're trying to hear, you're going to pick up all this shuffling and all this noise from Brandon's gown. It's really important you go stethoscope to skin to listen to your patient. It's going to be a much better assessment. Okay, so just to start, when we're listening to Brandon's anterior or front side of his lungs, I'm going to put in my ears. Now when I do this and I auscultate, now Brandon, I'm going to just kind of listen on each side of the chest. I want you to relax and breathe normally. What we don't want here is to Brandon to tell them to breathe and go and hyperventilate. This can wear out your patient and make it very difficult for you to hear and for them to maintain. So just have them breathe easily and at rest. Okay, so Brandon, I'm just going to take a quick listen here. Now, when I'm listening to Brandon, as you see, every inspiration and expiration is one breath. And again, no, I know I'm going over the clothes, but make sure you go skin to skin. So that way you don't pick up all of the sounds of Brandon's gown when you're listening. Good. Good. Okay, great. So I've listened to the anterior part of Brandon's chest, and when I did that, you saw that I went systematically from side to side and just kind of basically split the sternum there, kind of at this mid-line here. Okay, Brandon, so what I'm going to do is listen to your backside if you would. Do you mind just shuffling your feet on this direction so I can get to your back?
Perfect. Thank you so much. Now, if Brandon couldn't do this, you can have him lean up in bed or even roll to his side if you need to access his back. Okay, to listen here, it's going to be about the same method. So I'm going to kind of split Brandon's spine here and listen on each side. And we're going to listen with each inspiration and expiration as one, and move from top to bottom. Now this is really important here because many times, like if you have a patient with pneumonia, for example, sometimes you can't hear abnormal lung sounds such as crackles in the front, but you can sure hear it down here in the bases in the posterior or back side. Perfect, good. Thank you, Brandon. You can go ahead and lay on back for me. So this is also really helpful because you can also see the natural chest rise and fall for Brandon. Now that we're here and we've listened to the lungs, now we can go ahead and listen to the rest of the chest, which is Brandon's heart. So when we're doing this, we're listening to that lub-dub is 1, lub-dub is 2. And many times when we listen, there's certain medications and things like that that you need an accurate pulse, and we listen to the apical or the pulse here. Now when you're listening, you want to listen to the rate, meaning how fast is it, or is it very slow? Also, does it sound like a regular rhythm, meaning does it just tick, tick, tick on time, or is it abnormal, like tick, 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 tick? So if it's abnormal, that's also something to note. The patient can have an irregular heart rhythm or heartbeat. So when I listen to Brandon's heart, I want to listen to for what we call S1, S2, or that lub-dub, lub-dub. When I listen, I'm just going to split about the mid-clavicular line and take a listen to Brandon. Okay, perfect. So when I'm listening to Brandon, I can hear that lub-dub and listening again for an ample amount of time for a apical heart rate if you need to get that, and that normal rate and rhythm. Now, some patients, if they have a history of something irregular, take plenty of time, at least a full minute to listen. Now when we're talking about assessing the rest of Brandon's chest, it's a good idea, don't forget to look at the skin. So especially in your female patients, maybe under the breast line, look for redness, excoriation. Also, especially with our patient here, if they were in an accident, look for any signs of bleeding. So look up on the back, on the chest, up in the upper flank area. If you see any abnormal bleeding or bruising, you want to report that as well. So now that we've moved from our patient's chest, we've listened to their heart, listened to their lungs, now we can move down to their abdomen. So here's the really important thing to remember, is when we're talking about an abdomen, when we go to inspect, we can look, then we want to listen, then we want to percuss, or palpate. What I mean by this is you don't want to go pushing on and around Brandon's abdomen, because when I go to listen, that can stir up those bowel sounds, and that's not his true natural bowel sounds that we need to assess. So when I go to assess Brandon's abdomen, I'm going to go ahead and pull down your gown here for me. So I would raise Brandon's gown up and look here on his abdomen. Does it look distended? Now, is there any abnormal coloring? Is there like a yellowish? Do I see any signs of bleeding or bruising or anything abnormal? The other thing, this is a good time when you're inspecting the abdomen. Sometimes your patient has certain type of drain, such as an ostomy, that you want to check. Are there any signs of drainage or any signs of infection, such as redness or bruising or any sort of pus? Now, one more thing to note is when we're talking about inspection of the abdomen, sometimes you may see an abnormal bulging, such as a hernia, and you want to report that as well. So that's kind of some of the general things that we would look just to see if the skin integrity and all of that looks normal, and check for any drains. And of course, don't forget about any signs of infection. Now after inspection, now we remember to auscultate, which means listen, before we actually touch. So anytime you auscultate,
Here's an important point to note. Think about your abdomen in 4 tic-tac-toe pieces of the pie. So when I'm looking at Brandon's abdomen, I want to split this down the middle and across. It's important that we assess all 4 quadrants of Brandon's abdomen. Now we're going to take a look here. Does it sound really super gurgly and tumultuous? We call that hyperactive. Or does it sound very soft with a little bit of gurgling? We call that hypoactive. Now sometimes when we listen, if we can't hear anything, that's an abnormality and you definitely want to note that. We also want to know if you will hear any gurgling or anything high-pitched or any sort of whooshing sound. Anything like that you want to note and document in your assessment. Now just note, because everything's local, when I listen to Brandon's abdomen here, you may hear some of the heartbeat as well, and that's totally normal. So now I'm going to show you how we auscultate Brandon's abdomen. Okay, when I go to auscultate, after I've inspected, of course, I'm going to go the right upper quadrant here. And you only have to listen until you hear bowel sounds. Now, it may take a little bit of time for bowel sounds to be heard. You need at least listen to a good couple of minutes and wait to hear bowel sounds. Good, thank you. So when I listened, we're listening to the right upper, right lower, left upper, and left lower quadrant. So after we've inspected, really important with the abdomen, we've auscultated, then I can palpate the abdomen a little bit. Brandon, are you having any pain, anything like that?
Nope.
No? Feel comfortable? Okay. If you saw me push down on or palpate Brandon's abdomen, he started guarding or wincing, that could be a potential issue, and you want to document that. Now that we've moved through Brandon's abdomen here, we're going to look at his arms. So here with his arms, we can see these are appropriate color. We don't see any lacerations or bruising. We don't see any like deformities, for example, especially in the hands. Now where you may see this is if you have an elderly client with maybe arthritis, those nodules or anything like that. So we want to check through. Brandon's arms look healthy. We don't see any abnormal skin assessment. Also, if Brandon had any IV sites or any lines, make sure to assess those and those insertion sites. Do I see any streaking, redness, or pus? Do I see any redness? Is it hot to the touch? If that's the case, we want to check that. And of course, we want to feel. Skin looks great, feels nice and warm, it feels healthy, good muscular tone. And then we want to palpate our pulses. So when we palpate our pulses, you can check here up in the brachial area and bilaterally. Then we can check both in the radial pulses. Nice thing about assessment when you're moving this through, a lot of the times I can just do both of these radials at the same time. Now this is a very easy thing to practice when you're checking pulses. If you go down the thumb side just kind of very gently, flat, not like this, and palpate pulses, you can feel that easily with your patient. Now that I've went through that, I want to check the strength of my patient. It's a real easy way to do it. Now, Brandon, I'm going to put out 2 fingers. I want you to go ahead and squeeze for me. Don't be shy. Very nice, good. So here I'm assessing Brandon's strength. Also, do you notice when I asked Brandon to squeeze, he was able to easily move up his arms, squeeze and follow those commands. That wasn't an issue with Brandon. So I can see he's coordinated, he's got that strength. Also note that sometimes if someone's really weak because of illness or whatever that is, sometimes they may not be able to squeeze or raise their arms. That could just be the sign of weakness. Now, as I move through my head-to-toe assessment, I'm starting at the lower half of the body now and starting with the pelvis. So you've just got to be key about when this is important to note, especially with a patient like Brandon that was in a motor vehicle accident. But make sure you assess when's appropriate. So one thing we may need to inspect is coloring of the skin. So is there bleeding? Is there any bruising or some sort of lacerations? Also, sometimes it's appropriate in a trauma to palpate, but make sure that you don't do this if you are not trained. They may do this just to check for stability, but again, it may need to be deferred to the physician. So now we're going to move down and assess Brandon's legs. Now this is an area that people really frequently overlook. It actually tells us quite a bit. So when I'm inspecting Brandon's legs, I want to make sure I look at the skin coloring. It's also a good idea, and many times we don't. You want to check the patient's feet, and so it's important to remove their socks as well. Just going to remove these. Thank you, Brandon. Okay, so when I'm inspecting his legs, I'm looking for color here. Is there any discoloration? Do I see any lacerations or bruising? And the other thing is we want to check the skin and the toenails as well. Now, if need be, and you're worried about circulation, you can check capillary refill on your patient's nails by simply pushing down and applying pressure and letting go. And then within 3 seconds, the color should return back to normal. So that's just one way that we check circulation, and also feeling for warmth as well and any excess moisture. So again, upon inspection, one thing really to note about color, now certain diseases with patient like venous or arterial disease, you may see a lot of redness, or you may see a lot of dark and purple color on the shins here, and that's important to note. Now we also want to look for any deformities, especially if they were in a traumatic accident, and edema. That's a biggie. So I want to check on my patient's legs, and one way we check for edema is by simply grabbing here, or especially around the sock area, and just holding and see if we see any indentation. Now when we assess for edema, just a simple way to do so, if Brandon's legs were really edematous, which for him, if I push down, there is no hardly indentation whatsoever. But if I push down and I counted 1 1,000, 2 1,000, 3 1,000, and it took it that long to return to normal, we would call that 3+ edema, or 2+, depending on how long it took to return to normal. Now here's another really important area to assess, especially in your diabetic patients. We need to check on the heels and make sure they're not boggy or soft. We also need to make sure we check for any diabetic ulcers or little pressure ulcers on the feet. Now, before we get too much further in regards to the feet, we want to check for pulses, and this is really important and a good thing to practice as a student. So we want to check, and if you kind of go between Brandon's big toe and his second toe, and just anytime we palpate, keep those flat, go down with about 2 or 3 fingers and palpate for what we call the dorsalis pedis and check for circulation. And again, anytime you're working down the body, if you've got 2 hands, you can assess at the same time. Now we're checking if it's thready or bounding, and we want to make sure absolutely that it's present. Now you can check the dorsalis pedis, and you can also check what we call the posterior tib here as well and check for circulation. Now once we've done that, one of the things also before we move on from the legs is you want to check for strength. Now one thing I like to do with our patients is have them push down like they're pushing on the gas. So Brandon, if you will push on me like you're pushing down the gas, perfect. Then I'm going to put my hands up here and have Brandon pull towards his face. All right, point your toes and pull towards your face. Perfect. Very good. Now that's a really easy way as the push-pull to assess for strength in a patient that's in the bed. The other thing you can do, you can have them lift their leg one at a time. So I may do something like this. Okay, Brandon, I'm going to have you put your left leg up to my hand, and I'm going to count to 5 and keep it up there. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5. Excellent. So we would repeat the same thing on the other leg. And one thing we can do as well for strength and then check coordination. Now, if you can, take your heel and kind of rub up and down your shin with the opposite heel. Perfect. Very good. Thank you, Brandon. And then we would have him repeat it on the other side. Now, just note, anytime if a patient's really ill or they're really weak and they cannot do the heel to shin, this does not mean that they don't have coordination. That just means they have a really reduced strength. Now that I've finished assessing Brandon's legs, now here we check for coloring, checking for circulation and strength. I'm going to cover him back up for comfortability. Then don't forget to make sure you assess your patient's groin and buttocks when appropriately. Now we've got to be ensured that we inspect for coloring or discoloration, any sort of bruising, excoriation, or pressure ulcers. That's a major issue for many clients, especially when they're ill. Now, many of these can come up on any pressure point, especially in the backside at the top of the buttocks, in the sacral or the coccyx region of your patient. Now, also assess that sometimes there's a particularly foul smell from this area that we want to assess this, and this could be a hygiene issue or the patient's inability to care for themselves. And lastly, if there's any indwelling catheters, make sure you are diligent to inspect this as well, especially around the insertion site. And check that line for any kinks or tubings and it's draining appropriately. Thanks for hanging out with us today.